What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my Neuroanatomy playlist. In previous videos, we have talked about the brain, the spinal cord, the cranial nerves, the spinal nerves. We talked about the spinal cord, the tracts of the spinal cord, and the lesions of the spinal cord. Today, it's time to talk about pain, because no pain, no gain. Where did this word even come from? Are there different types of pain? What are the pain pathways in the human body? And what is the gate theory of pain? Let's find out. Click the like button, click the subscribe button, and let's get started. This is my Neuroanatomy playlist. Please watch these videos in order for maximum understanding and retention, not to be confused with my patient's urine retention. The subject of pain has inspired many poets and authors throughout history. But what does the word pain even mean? It comes from the Latin pena, which means a fine or penalty. Penalty, pena, penal law, etc. It's the fine, it's the penalty that your body has to pay whenever the pain pathway is triggered. Is pain something sensory or something motor? It is a sensation, for sure, that can provoke a motor response or a behavioral reaction. For example, your pain can be so severe that you start banging your head against the wall and feeling severe agony and discomfort, etc. The word nociception means pain reception, pain sensation. The pain receptors are known as nociceptors. As you know, your body has receptors for vibration, for proprioception, for temperature, for pressure, receptors for touch, and also receptors for pain. A noxious stimulus is one that causes pain, and this could be a thermal stimulus, a mechanical stimulus, or a chemical stimulus. Touching a very hot stove is painful. Being hit by a car or by any object is painful. And pouring acid into your wounds is extremely painful. Are there some chemical mediators that can trigger pain? Absolutely. And these include, but are not limited to, serotonin, also known as 5-hydroxytryptamine, bradykinin, prostaglandins, such as prostaglandin E, histamine, interleukins, TGF-beta, VEGF, which is vascular endothelial growth factor, TNF-alpha or tissue necrosis factor alpha, interferon gamma, and substance P. Please remember substance P for pain. P for pain. What these inflammatory mediators do is that they lower the threshold for pain sensation, making it easier for you to feel pain. There are two medical terms used to describe excessive pain. One is called hyperalgesia, which is bad, and allodynia, which is the worst. This is the devil. What does hyperalgesia mean? Algesia means pain, and that's why the word analgesia means no pain. But hyperalgesia means more pain, where the painful stimuli become even more painful than expected. But allodynia is different. Allodynia is where a painless stimulus becomes painful. For example, if a breeze of air, a gust of wind touches your face, you certainly feel it, but it should not be painful. But in these patients who suffer from allodynia, even a breeze of wind can cause extreme pain. We see this in some cases of thalamic pain syndrome, which can happen after a stroke that affects the thalamus of the brain. To learn more about strokes, please refer to my neurology playlist. If you wish to see more videos like this in the future, please drop a brain emoji in the comments. Where have we learned about prostaglandins before? Well, if you have watched my pharmacology playlist, you should. We start with membrane phospholipids because you know that you have trillions of cells. Each cell has a phospholipid bilayer membrane. From that phospholipid bilayer membrane, we can liberate arachidonic acid, which comes from linoleic acid, which is an essential fatty acid. How do you liberate arachidonic acid from the tyranny of membrane phospholipids? The answer is by a doozy enzyme known as phospholipase A2, an enzyme that breaks down the phospholipid, phospholipase A2, which needs vitamin B6, by the way. Once you get your arachidonic acid, you have one of two pathways in front of you. You can enter into the cyclooxygenase pathway, or you can delve into the lipooxygenase pathway. The cyclooxygenase path is going to take you to prostaglandins and thromboxane, whereas the lipooxygenase pathway is going to make you leukotrienes. Why do we call them leukotrienes? In reference to the leukocytes, such as the neutrophils, the famous cells of acute inflammation. See my pathology playlist. Since today's topic is about pain, we will focus more on the prostaglandins. Arachidonic acid by cyclooxygenase enzyme is going to give us prostaglandins, usually starting with prostaglandin G2, which can then give us prostaglandin H2, which can give us prostaglandin D2 and prostaglandin E2. Prostaglandin E2 is for fever and pain. So fever and ew, pain, it hurts. It also gives us prostaglandin F2 alpha. All of these prostaglandins, of course, can mediate acute inflammation. Because what are the cardinal signs of acute inflammation? Redness, hotness, swelling, pain, loss of function. Rubor, calor, tumor, dolor, functulaceae. Prostaglandins can lead to fever and pain. Let's sprinkle some pharmacology on top. Do you remember phospholipase A2? Yeah. That liberated arachidonic acid from the tyranny of the membrane phospholipids? Yeah. Can we inhibit such an enzyme? Of course, by giving corticosteroids, otherwise known as glucocorticoids. Now there is no arachidonic acid, there are no prostaglandins, and there is less fever, less pain, and less inflammation. And that's why many patients who have severe pain symptoms will go to consult a pain specialist that usually injects their joints with corticosteroids. Now you understand why. Next, do you remember cyclooxygenase enzyme, which converted arachidonic acid to prostaglandin G2? Well, you can inhibit this enzyme by non-steroidal, as opposed to steroidal, anti-inflammatory drugs and or aspirin. And that's why they are pain medications, because they are anti-pain. Now you know how. See, medicine makes so much sense once you understand what the flip you're talking about. Please watch my video titled Arachidonic Acid in my pharmacology playlist. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. This video was brought to you thanks to a generous donation from Rachel. She requested that I make a video on this subject. So please say thank you to Rachel in the comments. Thank you in advance. And if you want me to make a video about any subject in medicine, just go to my website, medicosisperfectionalis.com, where you can book such a service. Now, the first video in this glorious neuroanatomy playlist, the best on the planet, we had an introduction to neuroanatomy, in which I did teach you to always draw your line in the sand, passing by the central sulcus of the cerebral cortex. Anterior is mostly motor, posterior is mostly sensory. Motor fibers are descending fibers. They start up here in the brain and then descend to the face or to the rest of the body. These are descending efferent fibers. Conversely, sensory fibers start in the periphery, your fingertips, your toes, your skin, your muscles, your joints, etc., and then they send these signals all the way up to the cerebral cortex behind the imaginary line. Therefore, sensory fibers are ascending and afferent. They are ascending, they are afferent. You need to feel first, then react. Sensory before the motor. And that's why the Brodmann areas for sensation are 1, 2, 3, which come before 4. You need to feel first, then react. The A comes before the E as a mnemonic, and the A comes before the D. Ever wonder why this is the primary motor cortex? Because it's in front of the line. But behind the line, we have the primary somatosensory cortex. This is the part of your brain that actually feels the pain and can localize the pain depending on its type. Some types of pain are well localized. I can tell that the pain came exactly from my left little toe on the right side. But other types of pain are not so well localized. Instead, they are poorly localized, such as the pain caused by early appendicitis. It is a vague, weird, achy type of pain that is somewhere around the umbilicus. But hey, medicosis, the appendix is way down here and the umbilicus is way up here. They are not even close. Yes, because this pain is poorly localized. More on that later. Again, what is the center of pain sensation in the cerebral cortex? It's the primary somatosensory cortex, Brodmann area 1 to 3 or 3, 1, 2. Motor is anterior, sensory is posterior. This is how I contract my biceps muscle. This is how I feel pain. Next, let's try to move my eyes up and down, right and left. Frontal eye field. Surprise, surprise, it is in front of the imaginary line because it's motor. But let me see you and observe you. Oh, vision. Vision is a sensation. And that's why the primary visual cortex is behind the line. It makes sense. Now let me talk and articulate and move my laryngeal muscles. This is Broca's area in front of the line. But let me hear you and understand you. Understand is a sensory function. This is Wernicke's area behind the line. Medicine makes so much sense once you understand what the flip you're talking about. Is the human body really organized this way, or is this something that I've pulled out of my intergluteal cleft? It is literally organized this way. If you remember embryological development during the intrauterine life, this part came from the alar plate, which is sensory, but this part is derived from the basal plate, which is motor, and between them, there is the sulcus limitans, or limiting sulcus. That's the imaginary line. That's my line in the sand. The subject of embryology is of utmost importance. See my embryology playlist. And as my ancient boy of antiquity, Aristotle, once said, quote, "He who sees things from their beginning will have the finest view of them." Shame on your professors for not teaching you embryology well. And that's why you need a medicosis in your life. Medicine is not something I do. Medicine is who I am. By the same token, in the spinal cord, which is also part of the central nervous system, just like the brain, you draw your line in the sand, the sulcus limitans. Anterior is mostly motor. Posterior is mostly sensory. This is your anterior median fissure. This is the posterior median sulcus. When you see the gap, that's anterior. But when you see no gap, this is posterior. A fissure is a gap. A sulcus is not. On the inside, we observe the gray matter of the spinal cord. But on the outside, we see the white matter. The gray matter is divided into 3 horns. The posterior horn, the lateral horn, and the anterior horn. As for the white matter, it is divided into 3 funiculi or columns. This is the posterior column or posterior funiculus or dorsal funiculus, lateral column or lateral funiculus, anterior column or anterior funiculus. Next, right here, there is the central canal of the spinal cord, which contains cerebrospinal fluid. This is the same fluid that fills the ventricles in your brain. Then we have a very important definition, which is the word commissure. What does commissure mean in neuroanatomy? It means a connection between the right half and the left half. So a commissure contains a bunch of nerve fibers crossing from right to left or from left to right, doesn't matter, but connecting the right half of the CNS to the left half of the central nervous system. There are commissures in the brain and commissures in the spinal cord. In the spinal cord, in the white matter, we have anterior white commissure in front of the central canal and a posterior white commissure behind the central canal. And inside the gray matter, there is an anterior gray commissure in front of the central canal and a posterior gray commissure behind the central canal. How about the commissures in the brain? Can you name the brain commissures? Please comment below. Next, remember my line in the sand. Okay, therefore the posterior horn, sensory. Lateral horn and an anterior horn, both are motor. This one is motor autonomic, but this one is motor and somatic. Since today we are concerned with pain, which is a sensation, you should focus on the posterior horn and on the afferent root or the dorsal root or the posterior root, which has a dorsal root ganglion, something that's only in the dorsal root but not present in the ventral root. So, the afferent root contains sensory fibers, whereas the efferent root contains motor fibers. Both of them are going to unite together to form a common spinal nerve. So, by definition, the spinal nerve is mixed. It has to contain sensory fibers as well as motor fibers. Every spinal nerve in your body is mixed, sensory and motor. However, the root is not mixed. The posterior root is purely sensory. The anterior root is purely motor. We're not gonna worry too much about the rami in this lecture, but if you want to learn more about them, please refer to my neuroanatomy playlist, especially my video on the spinal cord. Next, some definitions. Central nervous system versus peripheral nervous system. What is the central nervous system? The brain and the spinal cord, and that's it, nothing else. However, anything that comes out of the brain or out of the spinal cord is peripheral nervous system because it lies on the periphery or peripheral to the central. And this is something that most students do not understand, which is the fact that your cranial nerves, by definition, are peripheral nervous system, not central. But hey, medicosis, my cranial nerves are located within the skull. But that's not the definition. The definition is not whether you are inside the skull or outside the skull. The definition is whether you are part of the brain and spinal cord or you're something else. And the cranial nerves are not part of the brain. They are attached to the brain, but they are not the brain. So the brain itself is central, but the cranial nerves are peripheral. The spinal cord is CNS, but the spinal nerves are PNS. Is this important to know? Of course, because there is a disease that demyelinates the central nervous system. We call this multiple sclerosis, which is going to destroy your brain and or your spinal cord. However, there is a totally different disease known as Guillain-Barré syndrome or acute demyelinating inflammatory polyradicular neuropathy or something like that. This disease demyelinates the peripheral nervous system, including the nerves, but it does not cause demyelination of the brain and the spinal cord. Now you know why. You can learn more about MS and GBS in my neurology playlist. Nervous system is either central or peripheral. The CNS is brain and spinal cord. The PNS is cranial nerves and spinal nerves. How many cranial nerves do you have? The answer is 12 pairs. How about the spinal nerves? You have 31 pairs. What is the structural unit of the nervous system? The answer is the neuron, which has a soma and an axon. How about the functional unit? And the answer to this is the reflex arc. The reflex arc happens, well, reflexively, i.e. without conscious thought or intention. You touch the hot stove and boom, you remove your hand from the hot stove. It happens before you have time to think, before the brain notices anything, because this is a spinal reflex. And as with any reflex arc in the human body, it follows the acronym SARASIR, which is an Arabic word that means cockroaches. The S is the stimulus. In this case, it's the candle or the stove, which is hot. R is the receptor. Those are thermoreceptors. But also, if the stove is very hot, it can stimulate pain receptors. The A is the afferent, which passes by the afferent or the dorsal or the posterior root of the spinal cord. And these fibers include A delta fibers as well as C fibers. More on that later. The C is the center, which has to be part of the central nervous system. In this case, it is the spinal cord. The first E is the efferent. The efferent is a somatic motor fiber that starts from the anterior horn cell, otherwise known as the motor neuron or alpha motor neuron. The second E is the effector organ. In this case, it's your biceps muscle or any other skeletal muscle that allows you to respond. The response is to contract your biceps and remove your hand away from the hot stove. That's a reflex arc. This is the afferent fiber, which has a cell body in the dorsal root ganglion. What type of neuron is this? Some people say, oh, it's bipolar because it has one pole here and one pole there. Nuh-uh, not true. If you look close, you have the cell body, which looks like this, and then you have the axon that goes this way. So how many poles? The pole is what leaves the soma. What leaves the soma is only one thing, not two things, just one. And that one is going to branch later. But it's pseudo-unipolar or unipolar because it has one pole. It has one pole, but from a distance, if you squint your eye, it appears as if we have two poles, even though it's unipolar. That's why we call it pseudo-unipolar. Next, this red neuron is the efferent neuron that's reaching your skeletal muscle. How about this blue one? It's an interneuron. Inter means in between. It's a neuron between two neurons. Interneuron. The reflex that we have just discussed is a polysynaptic reflex because we have two synapses. Here's the first synapse between the afferent neuron and the interneuron, and here's the second synapse between the interneuron and the motor neuron. So we have more than one synapse, hence polysynaptic. However, there is another reflex that is monosynaptic, and this is the stretch reflex, otherwise known as the myotatic reflex. So here is a mnemonic for you. The myotatic reflex with an M is monosynaptic with an M, meaning it only has one synapse between the afferent and the efferent, and there are no interneurons. That's why it only has one synapse, monosynaptic. Remember, in the spinal cord, the gray matter is on the inside, the white matter is on the outside. But in the brain, it's reversed. The gray matter is on the outside, but the white matter is on the inside. When you see white matter, it means those fibers are myelinated. But when you see gray matter, it means one of two things. Either A, unmyelinated fibers without myelin, or B, a bunch of somas, because by definition, the soma cannot be myelinated. Some axons are myelinated, others are not, but all of the somas are non-myelinated. You cannot myelinate a soma. What are the name of the cells that myelinate the axons in the central nervous system? How about the cells that myelinate the axons in the peripheral nervous system? Comment below if you know the answers. Remember, this is called the soma or the cell body, and this is the axon. A bunch of somas gathered together in the CNS is called a nucleus, but a bunch of somas located in the peripheral nervous system is a ganglion. Next, a collection of axons in the CNS is called a tract, but a collection of axons in the PNS is called a nerve. For example, the motor nucleus of the facial nerve is a nucleus. It's a collection of somas or cell bodies in the CNS, in this case in the brainstem. The dorsal root ganglion that we've just seen is a ganglion. It's a collection of somas in the peripheral nervous system, because if you remember, the spinal cord was here. This is part of the central nervous system, but the dorsal root ganglion was way out here, which is not part of the central nervous system. Today, we will learn about the spinothalamic tract. It's a tract. It's a collection of axons in the CNS, in the spinal cord and the brain. And then we talked about cranial nerves today and spinal nerves. For example, the facial nerve or the vagus nerve. A nerve is a collection of axons in the peripheral nervous system. And to belabor the point, because it's worth belaboring, suppose that this is the motor nucleus of the facial nerve, which is a collection of somas in the central nervous system. Now notice the facial nerve itself. Oh, the facial nerve is a collection of axons that has already left the central nervous system and is now heading peripherally. This is the facial nerve. This is the motor nucleus of the facial nerve. As you know, a bunch of somas can never be myelinated, so this motor nucleus of the facial nerve has to be part of the gray matter, not the white matter. How about the axons? Well, the axons could be myelinated or not. The facial nerve is very important, and it has motor somatic functions, and therefore it is myelinated. In my neuroanatomy playlist, I have a video talking about the spinal cord anatomy in detail, and another video discussing the spinal cord tracts, such as the corticospinal tract, dorsal column medial lemniscus system, and spinothalamic tract. Corticospinal. I start cortico in the cortex, and then I head to the spinal cord. Oh, so is this ascending or descending? This is descending. And if something is descending, is it motor or sensory? It has to be motor because it's efferent. Next, dorsal column medial lemniscus. The dorsal column is the back of the spinal cord. The medial lemniscus is in the brainstem. So it's heading upwards. It is starting downstairs and heads upstairs this way. Therefore, if it's ascending, it is afferent and therefore sensory. This is a sensory pathway. Next, spinothalamic tract. Follow the words. It's Gordon Ramsay style. F me, let the knife do the work. Let the medical terminology do the work. What do you have here? Spinothalamic. Spino, then thalamic. I start in the spinal cord and I head up towards the thalamus. If I'm heading up, I am ascending, I am afferent, and I am sensory. Therefore, corticospinal tract is motor, but the dorsal column and the spinothalamic tract are sensory. Since today we're talking about the sensation of pain, we shall discuss the spinothalamic tract, because the spinothalamic tract is responsible for conveying the following sensations. These include pain, temperature, crude touch, crude pressure, deep touch, deep pressure, and itching. Here's a question for the pros. Let's imagine that you have a patient who suffers from itching. and this patient has jaundice. And if you have to play odds, do you think this patient has A, increased level of unconjugated bilirubin, or B, increased level of conjugated bilirubin, and why? Let me know your answer in the comments. You will find the answer key in my video titled Bilirubin and Jaundice, which you can find in my physiology playlist. Now let's talk about the pain pathway. Are you having fun? See, I can teach neuroanatomy to a freaking donkey, and the donkey is gonna like it. The spinothalamic tract. I'm gonna start in the spinal cord and head towards the thalamus, and between the spinal cord and the thalamus there is a brainstem. A collection of axons in the brainstem is termed a lemniscus. There are 4 lemnisci that you need to know about: medial and lateral, trigeminal and spinal. Today we're concerned with the spinal lemniscus, which is part of the pathway that conveys pain from the body, excluding the face, to the brain. Let's talk about the spinothalamic tract. Please don't freak out. What are the sensations or the stimuli? We have pain, we have temperature, we have crude touch, crude pressure, deep touch, deep pressure, and itching. The pain and the temperature are carried by the lateral spinothalamic tract, which is going to pass laterally, whereas the crude touch and the itching are going to the anterior spinothalamic tract, which will be more anterior than lateral. That was the stimulus. Next, the receptor. The receptors for pain are free nerve endings. Why do they have to be free nerve endings and not covered by anything? Because pain is going to damage those receptors. Let's suppose hypothetically that you started with something sophisticated like a Pacinian corpuscle. Every time you'll feel the pain, you'll destroy your Pacinian corpuscle, and then you will have to regenerate it again, which will consume tons of resources and lots of time in a world of scarce resources which have alternative uses. And that's why pain had to be carried on the cheapest types of fibers, the most basic, which are the free nerve endings. Next, the afferent fibers. We have A delta fibers and we have C nerve fibers. These are 2 different types of fibers. If you have watched my physiology videos on nerve physiology, you would remember that type A fibers are thick and myelinated, but type C fibers are thin and unmyelinated. These are large fibers, these are small fibers. These are fast fibers. The conduction here is very fast, but C fiber, slower conduction. And that's why for the sharp, quick, well-localized pain, the acute pain is carried by the A delta fibers, such as stubbing your toe into the couch while walking at night. That's a fast, acute, well-localized pain. Conversely, C fibers are for the dull, achy, poor localized chronic pain or throbbing pain. This is the pain of the early stages of appendicitis. It is poorly localized. This is the pain of myocardial infarction, poorly localized. And that's why if I have myocardial infarction, you will find me pointing to the site of the pain by the entire hand, because the pain is so vague. I can never pinpoint the location of the myocardial infarction with one finger. It's not going to happen because it's not a well-localized pain. Instead, myocardial infarction is a poorly localized, dull pain carried by the C fibers. Pricking pain, oh, that's fine. That's sharp. That's A delta. But heat and chemical irritation, that is C fiber. A delta fibers have a higher threshold of activation, but C fiber type have a lower threshold for activation. Pricking sensation, this is sharp, so it's carried on the A delta fibers. How about itching? C fibers. Sharp pain, A delta. Dull pain, C fibers. Well-localized pain, A delta. Poorly localized pain, C fibers. Fast pain, A delta. Slow agonizing aching pain, C fibers. Acute pain, A delta. Chronic pain, C fibers. Throbbing pain, C fibers. Next, the temperature. A delta fibers carry warm and cold temperature sensations, but C fibers are mostly for the warm sensations. Next, the deep touch and the deep pressure are carried by the A delta fibers, but the crude touch and crude pressure are carried by the C fibers. So we are done with the stimulus, with the receptor, and the afferent. And of course, the afferent is going to be the first order neuron, which is going to end up in the posterior horn of the spinal cord. And of course, the cell body is located in the dorsal root ganglion. These are pseudounipolar cells, which terminate at the posterior horn or the dorsal horn of the gray matter of the spinal cord, particularly lamina 2, which is known as the substantia gelatinosa of Rolandi. All of this was just one fiber. We call this the first order neuron. Then after this, we will synapse with a second order neuron. The second order neuron is always going to cross the midline. In spinothalamic tracts, we are going to cross in the spinal cord. For example, in this case, from the left side of the body to the right side of the body, as you see. And then the second order neuron will ascend in the white matter of the spinal cord. In the lateral spinothalamic tract, if I'm carrying pain and temperature sensations, but in the anterior spinothalamic tract, if I am carrying crude touch and itching sensation. Whatever the case might be, I'm ascending in the white matter of the spinal cord, spinothalamic, until I hit the thalamus. While passing through the brainstem, we had a bunch of ascending fibers in the brainstem, which is the definition of a lemniscus. A lemniscus always consists of sensory fibers, not motor fibers, because they are ascending, so they have to be sensory. The lemniscus of the spinothalamic tract is called, well, spinal lemniscus. Imagine my shock. The second order neuron is going to end up in the thalamus. Which nucleus of the thalamus? Something called VPL, or ventral posterolateral, if we're talking about sensations from the body. Pain sensation from the body, not from the face. And that is the end of the second order neuron. It started here at lamina 2, the substantia gelatinosa of Rolandi, in the posterior horn of the spinal cord, crossed to the opposite side until it ended up in the thalamus. Next, the third order neuron will start from the thalamus, from the VPL nucleus of the thalamus, and is going to project upwards until we reach the cortex. Which part of the cortex? Since this is sensory, we have to be behind the imaginary line. This is the primary somatosensory cortex, Brodmann areas 3 and 1 and 2. For the pros, there is something called the Lissauer's tract, which means that these pain fibers are going to ascend for about 2 segments before they relay with the second order neuron, and then the second order neuron is going to cross about 2 segments above the level at which the pain was located. Here is a doozy comparison between A delta fibers and C fibers. So, in neuroanatomy, we have 2 methods of classifying these nerve fibers. The first one goes A, B, and C. The second one goes type 1, type 2, type 3, and type 4. So, the A delta fibers are equivalent to type 3 fibers, whereas the C fibers are equivalent to type 4 sensory nerve fibers. A delta, thick and myelinated. C fibers, thin and unmyelinated. These are large fibers, but these are small fibers. Faster conduction, slower conduction velocity. Higher threshold, lower threshold. Pricking versus itching. Sharp pain versus dull pain. Well localized versus poorly localized. Fast versus slow. Acute versus chronic pain. For the temperature, warm and cold, A delta. Warm only for the C fibers. Deep touch and deep pressure by the A delta fibers, but crude touch and crude pressure, C fibers. Here is another mnemonic. The C for crude goes with the C fibers. Heat and chemical irritation, C fibers. Where do you find the A delta fibers? On the outer coats. What do I mean by this? The skin, it's the outer coat of the body, and then the pleura, which is the outer coat of the lung. Peritoneum, think of this as the outer coat of the abdominal cavity, or the outer coat of the viscera. Large vessels, such as the aorta. And that's why the pain of aortic dissection is very sharp. Here is a dissecting thoracic aneurysm, or an aortic dissection, which keeps dissecting and dissecting and bisecting the wall, and descends and descends and descends. And the patient will feel the pain between his 2 shoulder blades, or 2 scapulae, and the patient will tell you that the pain started high and kept encroaching down and down and down. It is very well localized indeed, because this is a delta fiber. Contrast that with your heart's myocardial infarction. It's a poorly localized pain. The patient will be pointing with the entire hand. The patient will tell you, I feel as if an elephant is sitting on my chest. This is a poorly localized quality of pain. Most viscera have C fibers, not A delta. The peritoneum and the pleura have A delta, but the viscera itself, For example, your intestines, small and large, have C fibers. And that's why, in early cases of acute appendicitis, where only the appendix is inflamed, the appendix is part of the viscera, which means it has C fibers, which means it's aching and dull and poorly localized pain that is going to radiate around the umbilicus or in the periumbilical region. This is what happens in the early cases of appendicitis. However, when the inflammation spreads and touches the surrounding peritoneum, guess what's going to happen? The peritoneum has A delta fibers. Now the pain starts to be sharp and well localized. And then the patient is going to tell you, you know what, doctor? I do not feel the pain around the umbilicus anymore. Instead, now I feel the pain on the right side in the McBurney's point, because now the pain is well localized. Who else is going to teach you like this? Your professor with his PowerPoint? Give me a break. For the pros, the lung itself, not the pleura, the liver itself, not the capsule of the liver, I'm talking about the hepatic capsule of Gleason, the pancreas itself, the spleen, and the brain substance do not have any pain sensation. So the brain that helps you feel the pain is itself insensitive to pain. And I'm sure you have seen those YouTube videos about a neurosurgeon working directly into the patient's brain, slicing and dicing the patient's brain tissue while the patient is chilling, solving a puzzle, playing a guitar, etc., and the patient feels no pain whatsoever. Cutting through the skull is gonna hurt like crazy. Touching the periosteum causes pain. However, the brain itself is not sensitive to pain. Patients who have liver abscess do not feel anything until the abscess creeps into the peritoneum. Then it becomes painful. Lung abscess per se is not painful, but once it reaches the pleura, #empyema, then it becomes painful. But how come acute pancreatitis hurts like crazy? Because it inflamed the peritoneum. Hey doctor, my spleen feels a little icky today, said no patient ever. So those are the pain pathways. Again, pause and review. We have a first order neuron, a second order neuron, which is going to cross to the opposite side in the spinal cord until we reach the thalamus. Then a third order neuron from the thalamus until the primary somatosensory cortex. Next, communications. The spinal lemniscus in the brainstem is going to communicate with the reticular formation, and that's why feeling pain makes you alert. It makes you unable to fall asleep because of the activation of the reticular formation. Next, those pain pathways communicate with the hypothalamus and the limbic system, causing emotions of agony, anger, and despair, which can influence your behavior. That's why many patients who are in pain treat their nurses and their doctors like absolute trash. I do not blame the patient. The patient is in pain. The pessimistic philosopher Arthur Schopenhauer, who was literally weaned on a pickle, has a very astute observation. I am paraphrasing, of course. He says that pleasure will always feel underwhelming, below your expectations. On the other hand, pain will always feel worse than anything you have ever expected. So, doctors can read all day long about the pain of appendicitis. Until it happens to you, the pain will be way worse than anything that you have ever predicted. So you need to have some empathy for your patient. Next, of course, we communicate with the primary somatosensory cortex to be able to localize the pain. Next, chemical mediators of pain, serotonin and bradykinin and prostaglandin and the acid and caspacin and histamine and interleukins and TGF-beta, VEGF, TNF-alpha, interferon gamma and substance P for pain, of course, can lead to more pain sensation. You can say they lower the threshold of pain. Conversely, beta endorphins, dynorphins, enkephalins, these are natural. Anandamide, also natural. Morphine, not natural. These tend to cause less pain. They are painkillers. Beta endorphins work on the mu receptor, dynorphins on the kappa receptor, enkephalins on the delta receptors, morphine mainly on the mu receptor, but also others. Anandamides on the cannabinoid receptors, CB1 and CB2. Next, my favorite part of the lecture, the gate theory of pain. Now get a piece of paper and doodle with medicosis. Alright, here is the gate. Alright, this gate is open as you see. And let's draw Mr. Pain, okay? Here is Mr. Pain and Agony, alright? He looks grumpy. If the gate is open, the pain is gonna be able to reach your brain. And if it reaches your brain, of course, you're gonna feel severe pain. Why? Because the gate is wide open. However, what if we are able to close the gate? If you close the gate, Mr. Pain will not be able to access your brain. Access is denied, and you will feel no pain. Again, here's the gate. The gate is wide open, therefore Mr. Pain will come through it, and you will feel an ouchie. Why? Because substance P was released from the C fibers. But what if the gate is closed, access is denied, and the C fibers will be inhibited? They will not release substance P. No substance P, no pain. And as the old English proverb says, no pain, no pain. That's the gate theory of pain. Look, the brain is just chilling. Now, how can we close the gate and prevent pain sensation? The answer is via presynaptic inhibition, which is the buzzword of the buzzwords. It's the mother of all buzzwords. To understand what presynaptic inhibition is, we need to talk about synapses. This is a synapse. This is the presynaptic fiber. This is the postsynaptic fiber. Presynaptic is here. Postsynaptic is there. If I can find a way to inhibit the presynaptic neuron, this phenomenon will be termed presynaptic inhibition, and the substance P will not be released and pain will not be felt. This is presynaptic inhibition, just like this one. This is what closes the gate, prevents the release of substance P, therefore no pain. You're talking about the gate ad nauseum. Where the hell is the gate? The gate lies between the end of the C fibers and the substantia gelatinosa of Rolandi or lamina 2 in the gray matter, particularly in the posterior horn of the spinal cord. And when you inhibit your C fibers, you're not going to release substance P. You're not going to activate the second order neuron in the substantia gelatinosa of Rolandi in the posterior horn of the spinal cord, also known as lamina 2, which means the pain is not going to ascend to the brain and you will not feel an ouchie. Hashtag gate theory of pain control. If you have watched my video on the cerebral cortex, see my neuroanatomy playlist, you shall recall the Brodmann areas, which help us organize and map the cerebral cortex of the brain. But should we ignore the spinal cord or something? Of course not. The spinal cord deserves a map, so you get a map, and you get a map, and you get a map. This is Neuroanatomy Oprah Winfrey style. But instead of Brodmann this time, it's the Rex laminae. This is the dude who named them. And since you need to feel before you react, therefore the afferent has to come before the efferent. Therefore, you have to start numbering from the back, which is very similar to Brodmann's classification, because Brodmann gave number 1, number 2, and number 3 to the sensory cortex, and then number 4 to the motor cortex. Sensory before motor. Same thing here. Rex gave the lower numbers 1, 2, 3, 4, 5, 6, etc. to the sensory part, 7 to the lateral horn, 8 and 9 to the anterior horn, and 10 is hanging around the central canal of the spinal cord, also known as the gray commissure. Some important names for the pros. Lamina 1 is also known as the marginal nucleus because it's at the margin. It's not a Scooby-Doo mystery. Next, lamina 2, which is today's topic, is the substantia gelatinosa of Rolandi. This is painful. 3 and 4, nucleus proprius. I'm scratching my beard as we speak. What do you think the function of nucleus proprius is? I can hear my students shouting from the back of the class, it's for proprioception. True. Proprius is for proprioception. Who could have thought? Next, lamina 5 is called the neck of the dorsal horn, and lamina 6 is the base of the dorsal horn. Not very impressive. Next, lamina 7 is known as the intermediate nucleus because it's in the intermediate area near the lateral horn. And in some parts of the body, it's known as the dorsal nucleus of Clark or Clark's nucleus. And I've talked about Clark's nucleus in my videos on the cerebellar tract, which you can find in my neuroanatomy playlist. Lamina 8 is the motor interneuron, and lamina 9 is the motor neuron of the anterior horn cell. Please note the difference between the gray commissure, lamina 10, and the white commissure. Anterior white commissure, posterior white commissure. Remember when we talked about the spinothalamic tract? Yeah, The fibers of the second order neuron started at lamina 2, which is the substantia gelatinosa of Rolandi, and then the axons or these fibers crossed the midline through the anterior white commissure, and then they went to the lateral spinothalamic tract or anterior spinothalamic tract until they reached the thalamus. You see this lamina 2? This is where the gate is. So the gate lies between the first order neuron and the second order neuron. The gate lies between the end of C fibers, first order neuron, and lamina 2 at the substantia gelatinosa of Rolandi, which is the beginning of the second order neuron. Between the first and the second order neurons, this is where the gate is. And when you close the gate, the first order neuron, which is the C fiber, is not going to release substance P. Therefore, the second order neuron is not going to be activated, and therefore you're not going to feel the pain. Between the first order neuron and the second order neuron, there lies the gate at the substantia gelatinosa of Rolandi, which is lamina 2. So when the gate is open and when you are exposed to a painful stimulus, those first order neurons are going to secrete substance P, which is going to activate the second order neuron, which starts at the substantia gelatinosa of Rolandi or lamina 2, and then it crosses in the anterior commissure and you feel the pain. This is what happens when the gate is open. But when the gate is closed by means of presynaptic inhibition, we're going to inhibit these C fibers, these afferent fibers of the first order neuron, and therefore the second order neuron shall not be activated and you shall not feel any pain whatsoever because the gate is closed. Pause and review. What if I told you that the gate cell is an inhibitory interneuron, a neuron between two neurons, interneuron? Some people call it the T cell or the gate cell, not to be confused with the T lymphocyte. So how can we close the gate? We have three ways of doing so. One, by opioid peptides, which act on G protein coupled receptors, which are GI coupled to be specific, or two, supraspinal impulses coming from above the spinal cord. This is a euphemism for your brain, or from the spinal cord itself. Let's talk about each one of these mechanisms, starting with the opioids, also known as opiates or morphine and his cousins. We divide opioids into endogenous and exogenous opioids. The endogenous ones are the natural painkillers, endorphin, dynorphin, and cephalon. The exogenous is morphine and his cousins, meperidine, methadone, oxycodone, hydrocodone, oxymorphone, hydromorphone, fentanyl, alfentanil, remifentanil, and sufentanil. Codeine, tramadol, and tapentadol. Why does it end in ol? Because it has an alcohol group. The natural ones, endorphins act on mu receptors, dynorphins on kappa receptors, and cephalon on the delta receptors. For the super sophisticated students, we have something new called new peptide nociceptin, which acts on nociceptin receptors. The receptors for pain. Mu1, Mu2, kappa, and delta. Mu1. That's how your painkillers, whether endogenous or exogenous, cause analgesia. An means no, algesia means pain. So analgesia literally means no pain in the brain, and euphoria in the brain. By acting on mu2 receptors, morphine and his cousins can lead to respiratory depression, which is a central effect, and constipation, which is a peripheral effect. Opioid-induced constipation is such an important topic in medicine. Next, by acting on the kappa receptors, those painkillers contribute to analgesia, which is central, this time in the spinal cord more than the brain, and dysphoria in the brain. Dysphoria is the opposite of euphoria. Eu means good or true, dys means dysfunctional. Delta. By acting on the delta receptors, the morphine and his cousins contribute to analgesia and euphoria. Morphine's receptor is a G protein coupled receptor, particularly GI, which is the opposite of GS. GS means to stimulate, but GI means to inhibit. To inhibit what? To inhibit the pain. I have a video titled G protein in my endocrinology playlist. Here's the story of G protein. Let's start with GS, which is going to stimulate, and then GI is going to be the exact opposite of GS. GS is going to activate a bunch of stuff until you activate adenylate cyclase, which converts ATP into cyclic AMP, which activates protein kinase A, which adds a bunch of phosphate groups. So if something is GS coupled, it will increase CAMP, And when you increase CAMP or cyclic AMP, you will contribute to pain. This is what GS-coupled receptors are capable of doing. But morphine is different because its receptor is GI coupled. It's anti-GS. It's the opposite. It decreases cyclic AMP and decreases pain sensation. GS coupled receptors are going to activate adenylate cyclase and convert ATP to cyclic AMP, and you will have tons of cyclic AMP and you might feel some pain. But GI coupled receptors, thank you morphine, I'm going to inhibit adenylate cyclase, and therefore ATP will not be converted to cyclic AMP and I will have less pain. Hashtag analgesia. You can learn more about morphine and his cousins in my pharmacology playlist here on YouTube, or by downloading my neuropharmacology course at medicosisperfectionalis.com, which comes with videos, notes, and cases. It will teach you about opioids, anesthetics, stimulants, sedatives, and hypnotics such as benzodiazepines and barbiturates, anti-epileptics, antidepressants, antipsychotics, and anti-Parkinsonian medications. We are done with number 1. Now let's turn our attention to the second mechanism of closing the gate of pain. Supraspinal impulses coming from the brain. The brain, by an elaborate, sophisticated mechanism, is going to stimulate the inhibitory interneuron, also known as the gate cell. And therefore, this will inhibit the release of substance P from the first-order neuron, the C fibers. Therefore, you will not activate the second-order neuron and you will feel no pain. But we need to talk more about this elaborate supraspinal mechanism, i.e. its inhibition by means of descending impulses from the brain. We start by making endorphins by the hypothalamus and the pituitary. Then endorphins will leave the hypothalamus and the pituitary until they reach an area, a gray area, around the cerebral aqueduct of the midbrain, known as the periaqueductal gray area or periaqueductal gray matter, or simply periaqueductal gray. The neurons of the periaqueductal gray area are going to respond to the endorphin by making enkephalin. Enkephalin will leave the periaqueductal gray in the midbrain, and then they will activate a very important part in the pons and the medulla known as the nucleus raphe magnus. Nucleus because it's a collection of somas or cell bodies in the central nervous system. Magnus because it's big, magna. What does raphe mean? Oh, raphe means like this. Imagine that you has torn your shirt. How do you fix it? Oh, you fix it by raphe. This is raphe. Oh, you stitch it back together. Exactly. There is an area in the brain that looks as if it has been stitched together, known as raphe. And this nucleus raphe magnus in the medulla and pons is going to respond to the enkephalin by making their own serotonin. Serotonin activates the gate cell or the inhibitory interneuron, which will inhibit your C fiber by means of presynaptic inhibition. C fiber is not gonna make substance P and therefore is not gonna activate the substantia gelatinosa of Orlandi. You're not gonna activate the second order neuron and you will not feel any pain, because the gate is now closed. Some pharmacology integration. Opioids can stimulate the periaqueductal gray area of the midbrain and therefore inhibit from above. Inhibit the C fibers from above. Here is another mechanism. Opioids can stimulate something called NRPG, which stands for nucleus reticularis paragigantocellularis. Act as if I said nothing, which will activate nucleus raphe magnus, and therefore you can say that opioids activated the nucleus raphe magnus and therefore made serotonin and therefore activated the gate cell, which is going to induce and cast some presynaptic inhibitory curse on the C fiber, therefore no substance P release and no pain. Thank you, morphine and your cousins. Now let's zoom in on this inhibitory interneuron to see exactly how it works. First, before the inhibitory interneuron, act as if the inhibitory interneuron or the gate cell does not exist. This is pain, okay? We have sharp pain, we have dull pain, we have acute pain, we have chronic pain. We have well localized, we have poorly localized. These are A delta fibers, which are thick and myelinated. These are C fibers, which are thin and unmyelinated. Where is the soma of the first order neuron? It's always in the dorsal root ganglion. These fibers are in the dorsal root or the posterior root of the spinal cord. Of course, this is the first order neuron. The first order neuron always ends by synapsing with the second order neuron. Where is this exactly? In the substantia gelatinosa of Rolandi, in lamina 2, in the gray matter of the spinal cord's posterior horn. How did the first order neuron activate the second order neuron? By means of substance P. Substance P for pain. Then the second order neuron will in turn relay and convey those pain sensations to your brain after crossing to the opposite side in the anterior wide commissure in the spinal cord. This is how you feel the pain, okay? This means that the gate is wide open. Now let me add the inhibitory interneuron to the picture. This is the gate cell. This inhibitory interneuron or the gate cell is going to inhibit A delta fibers and it's going to inhibit the C fibers. How did the inhibitory interneuron inhibit both of these fibers? The answer is by releasing enkephalin. So when you release enkephalin, which is the natural painkiller, from the inhibitory interneuron, you're going to inhibit the A delta fibers and the C fibers. How did you inhibit them? By means of the mother of all buzzwords, presynaptic inhibition. Inhibition of what? Inhibition of the release of substance P, therefore no pain, and the gate has been closed. Okay, so it's the inhibitory interneuron or the gate cell that inhibits pain sensation. How do I get this inhibitory interneuron to function? Number 1, by opioids. Number 2, by descending inhibition, supraspinal inhibition from the brain. Thank you, endorphins, enkephalins, serotonins, and more enkephalin. But wait, there is a third method, spinal impulses. Another way of closing the gate. Another way of activating the inhibitory interneuron. Spinal impulses. Basically, some fibers from the spinal cord will come and activate the inhibitory interneuron, and when you activate the gate cell or the inhibitory interneuron, it will release enkephalin and cause presynaptic inhibition to the A delta and C fibers, and therefore prevent the release of substance P, and therefore prevent the sensation of pain. But how do I get the interneuron to activate by means of spinal impulses? Easy stuff. Of course, you have heard of acupuncture as a method of decreasing pain. You know how they work? They activate A delta fibers. How come? Well, acupuncture. Those are sharp needles, sharp, pricking. And if it's sharp and pricking, this is A delta fibers, not C fibers. When the acupuncture needles activate the A delta fibers are going to stimulate the inhibitory interneuron, stimulate the gate cell, and then the gate cell will inhibit the C fibers by means of presynaptic inhibition, and therefore this eliminates the pain. Let's say that you have a very bad neuropathic pain, for example. It means that your C fibers are irritated. Acupuncture might help you by stimulating the A delta fibers, which will then activate the inhibitory interneuron, which will then inhibit the C fibers, and you will feel no pain. So it's adding a sharp pain to relieve your dull pain. And of course, the dull pain is much worse. And this is how acupunctures work. Another mechanism is counter-irritation. Sometimes you have a patient who suffers from a certain type of pain. For example, my right foot hurts like mad. Then I suffer from another disease. For example, let's say I suffered trauma to my right elbow and it was so bad that I had to see a surgeon. Guess what? During this pain in my right elbow, I might forget about the pain of the foot. How on earth did this happen? Counter-irritation activates A delta fibers, and the rest is history. Some patches are used to treat pain. How do these patches work? Counter-irritation. They irritate the A delta fibers, which are going to inhibit the C fibers. That's the gate theory of pain. And of course, you have tried this before. Last time you hit your head or your arm at the frame of the door, what was the first thing you did? Oh, you rubbed it very quickly, or you wrapped something around it, or you pressed on it. You did anything to distract you from the pain, and it worked. How do these work? By activating something else. These purple fibers are not A delta, but rather they are A beta fibers. These A beta fibers can stimulate the inhibitory interneuron or the gate cell. The gate cell is going to inhibit the C fiber by means of presynaptic inhibition. Thank you, enkephalin. Then there will be no release of substance P and no pain. This is how wrapping, rubbing, pressure, sometimes vibration can distract you from the pain. And in my home country, Egypt, here is great-great-great-great-great-grandmother's recipe of treating headache or any type of pain. You simply wrap a tight band around your head or a tight piece of cloth around your head. Some people add a key to the piece of cloth, as in a key to your house. I've no idea why they add a key though. It's just some folk medicine, I guess. Or maybe because they understood that the key is gonna close the gate of agony. And that was the best explanation of the gate theory of pain ever. Don't forget to download my neuropharmacology course on my website. And please say thank you to this fine lady in the comments. And if you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 700 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.